Thanks very much for coming for the Boroff-Forman event, To Err is Human. I'm Howie Forman. I just wanted to briefly tell you what the game plan is and thank all the people that are involved in this. First of all, I just want to thank the Department of Diagnostic Radiology for sponsoring the event. I want to thank Morna Borgstrom and Harlan Krumholtz and Sally Romanis, wherever she may be sitting right now. And there we go. And, of course, Mike Eisenberg, who's in the back there, you can't miss him, who is the director of the film, for coming and participating in a panel that will follow the movie. Our timing is that I'm going to do this in like 30 seconds. Mike is going to come and give about a 2-minute introduction to the film, and then we're going to do the screening of the film, which is about 1 hour and 15 minutes. We'll take about a 5-minute stretch break in your seats where people can come and go, and then we're going to start the panel, and we're just really delighted that you're able to come here and participate in this. And I'm going to turn it over to Mike to tell you a little about the film. So thanks. And remember to just turn off your cell phones during the screening, and we will be dimming the lights. So thanks very much for coming here and sharing this with us. And thanks also to your wife and to Matt, who is the cinematographer. So thanks.
Thank you. I was going to first acknowledge Matt and Kaylee, who are standing back there. They're the co-producers of the film with me. We all worked on this together from day one. So while there is a personal connection in this movie for me, my dad was Dr. John Eisenberg, who ran the Agency for Healthcare Research and Quality. May or may not be familiar to some of you, but I'll allow that discussion to happen after the film if you're curious about the connections. Typically, I just like to say we'll let the film speak for itself and talk after. That is what the panel discussion is for. But obviously, just enjoy it and know that. Thank you. What was the thing I wanted to say? I was going to say one thing.
Howie did a great job with that.
Wow, that's last. Save the best for last. Yes, thank you. Sorry. This is pretty special screening. The movie won't come out until the fall. It's not going to be released to the general public until probably October, late fall, sometime around that. We haven't decided yet. But over the course of the next few months of the spring and summer, we'll be sharing it with audiences just like yourselves who understand that this is an important topic and want to learn more about it in a setting that is a little bit atypical than how it's typically discussed. That is our goal as filmmakers, and we hope that you learn, engage, and enjoy the film. Thank you again for setting this up. This is really a remarkable setup. I'm really excited for you guys to see the film. So without further ado, an hour and a half later, we will talk about it. Thank you.
Both my husband, Pat, and my son, Cal, experienced diagnostic errors. Cal suffered brain damage from his newborn jaundice when it was misdiagnosed. Today he has significant cerebral palsy. And Pat, my husband, died when he was 45 from a cancer that was appropriately diagnosed, but the pathology failed to get communicated to the doctor or Pat. It was hard for us to understand and believe that this could happen in a developed country like the United States.
If you look at many of the statistics as the third leading cause of death in the U.S., most people are completely unaware of that.
That is the equivalent of 7 or 8 airliners crashing every day with no survivors.
We're probably filling one Arlington cemetery every year from preventable medical harm.
Most of us in medicine just said, well, that's the way it is.
This is a problem that's, hiding in plain sight.
This is urgent. It's a public health emergency.
If you believe first do no harm, there is no excuse for not investing in things which will prevent harm.
We have to acknowledge that to err is human, and then to figure out what do we do with that fact in terms of building a system that's safe for patients.
We got to change it. We got to make it better, and I think many people are working very hard to make it better.
One of the ways to really make a difference is you've got to get patients engaged.
We could prevent many, many, many of these deaths immediately if we just put in the effort.
We need to think about them not as unavoidable, but as unthinkable.
To
To change patient safety, you have to change everything.
We built it completely wrong. This is a time for openness and honesty. It's not any longer a question of possibility, it's a question of will.
These are not just things that happen to other people. They happen to us, they happen to our families, and they are things that we need to work on.
I cannot change what happened to Cal and Pat. However, my family's story is also a story of awakening, of passion, of change, and hope for the future.
So we have let me just get started. We have a great panel, but I think everyone on the panel, as we've discussed, is interested in having this turn into a discussion and be interactive and to have us all have the opportunity to talk together. Mike Eisenberg, obviously the director and writer, originator, the leader of the team. It was a team effort, I'm sure, and Marna Borgstrom is well known to everyone. Like I said, I think it sends an important signal. Authentic and genuine. At the end of a long day, Marna's committed to being here, has seen the movie before, and sat through it again, and is here enthusiastically and immediately accepted the invitation to be part of this. And to me, that's just such important leadership. And Sally Romanis, a good friend of mine, a colleague, someone I've worked together, someone who's led patient safety efforts and has experienced the experienced issues around patient safety as well. So we have a really great group. I wanted to just take 1 second. I think Sue Sheridan is amazing. I don't know how she moves forward, but not only does she move forward, but she actually maintains such a spirit of positivity and such a determination to make a difference in the world. It actually has lessons far beyond even the narrow scope of what we're, and important scope, but the scope of patient safety. She, I think, instructs us, and I've had the pleasure and privilege of knowing her for maybe a little more than a decade. And when I first met her, I knew that she was a patient advocate, and I was impressed by her positivity. I couldn't have imagined actually what the backstory was, and as I learned about it, it only increased my appreciation for her. She is one of my heroes, and she inspires me. I just wanted to, just because I told her that we were doing this today, and she wrote a note back last night and said, "So nice to hear from you. Thanks for your kind words. I'm hopeful that Mike's film puts patient safety back on the radar. The real heroes," because I told her she's one of my heroes, "the real heroes are my kids. They're warriors and have taught me so much." But then she says, "I hope the screening is successful and everyone walks away from it committed to raise the bar." And I think that's just so Sue, and I think that worthy of what we've just seen, that's part of what our charge is to try to take this and continue to move things forward. Mike, I wanted to start with you on the panel and just whether you wanted to share any reflections of your journey with regard to this. And then I had told you there's so much in here and so well configured and presented. Is there something that was left on the cutting room floor that you thought also we should know about or that you wish you'd been able to include?
Oh, well, first of all, thank you for helping moderate this panel, and I really appreciate all of you guys coming out. It's amazing to watch the film with an audience. We spent many hours making this film in our office, which is essentially just a room with computers. And you don't get the opinions of others and the thoughts of others until you decide it's time to ask for them, which applies in many other ways to the discussion we'll continue to have here. But to hear reactions and to see people in the room, it always makes it worth it. So thank you for coming. As for the question, we got a lot. The film is relatively dense as it is because it's a massive topic to address. And it can't be done appropriately in one film. I mean, the best way of doing it might be to do a series of films and to tackle other topics in other ways. But for us, we really wanted to maintain a singular focus of what would my dad have done if he made this movie. That was a sort of genesis of thought for us along the way. And I really think that part of his passion was focusing on how to let good doctors do what they want to do. Care for patients and have those relationships that they want to have and do a good job, do no harm. One thing that a lot of people consistently thought was important was the malpractice side of things, lawsuits, legal. What about Sue's story? What did she do on the lawsuit side of things? And we felt like while that is a very important issue and something that maybe somebody else would be more suited to tackle, we really wanted to focus on how can we improve from the perspective of filmmaking and storytelling the healthcare system's understanding of safety and quality and working together as a team and allow them to speak for themselves. That's why we interviewed so many people in the film. So I think it's less a matter of cutting as it was a matter of omitting that portion of the story, but trying to acknowledge that it's still important and knowing that we can talk about this for a long time outside of the context of just the runtime.
That's great. I want to turn to the other panelists for reflection. I do want to say I was reminded about the error I've just made, which is I was supposed to say in the beginning that we're filming the question and answer. We want to be able for people to view and also engage even if they couldn't attend. And so you should just know if you say anything, the intent is to record and to show if there's anything you've got to say that you feel that you wouldn't want that, you might want to do it then outside the bounds of this question and answer and discussion period. So thank you. Marna, do you want to provide any reflections? And then we'll go to Sally next.
I think I just want to echo. I have seen this twice, as you pointed out, and the first time I saw it, I was incredibly moved and really focused mostly on Sue Sheridan and how she had the presence to do that and then to do what she's done since then to advocate for patient safety. And to you, because I think this is an amazing project that once you take this public, it's going to have incredible impact in all of healthcare. And so, I'm grateful that you took on this as a project because there isn't anything more important. And, I know from a lot of the people in this room who spend an awful lot of time on patient safety here that we have a developing good story to tell, but there's always much, much more that can be done. So I look forward to participating in the panel discussion, and thank you for having me and to Dr. Forman for putting this together.
Yeah, thank you to Howie for all the efforts. Sally, do you want to?
Yeah, I'm kind of.
And can you all hear? Are the microphones?
No. All right. Is that better?
I don't think they're.
Is it on? Is that better? Okay. I'm in a somewhat unique position in that in 1999, when the IOM report came out, I was here at the hospital, and I remember all the talk about could that be true. It was just inconceivable that that many people were dying from medical error and that we were hurting people. And Yale New Haven Hospital very quickly put together a patient safety steering committee. It was chaired by the medical chief of staff at the time, Dr. Peter Herbert, and I was part of that with Harlan and others, a lot of leadership from the hospital, and spent many years trying to think about the science of patient safety and how do you do this and how do you make people safer. And then in 2006, had my own medical error and became part of that statistic. I was home. My husband, who was an avid cyclist, was out for a ride, called me and said that he thought he'd had a cardiac event. He ended up in the emergency room here. And at the time, we were very grateful because he got in here quickly and he seemed to be stabilized, and he was taken off to have a cardiac procedure, to have a stent placed. And so after the procedure was over, we went up to the floor, and I met with his attending, who said everything had gone well. They were happy with the outcome. Met with the nurses and other people, and my daughter was home at the time visiting, who was a nurse in an ICU up at Mass General. And so when we left him, I remember leaving that night, kissing him goodbye and thinking, I'll be back tomorrow morning to take him home. and saying to everybody, let me know if there's anything at all you're worried about. Call me at home if there's anything at all you're concerned about. Let us know. We'll be happy to come right back in. Because Dean, my husband, had said, I can't stand you hovering. You have to go home and sleep. So we went home, and we received a call at 5 a.m. saying they were rushing him back to the cath lab. And my daughter drove me down to the hospital, and while she was parking the car, I walked into the hospital and looked up to the second floor of the atrium and saw a team of people rushing towards the cath lab and thought, oh my God, that's the code team. And ran up the stairs, following that team of people into the cath lab, only to see them doing chest compressions on my husband. And after, you have that moment of time that's so surrealistic because you're thinking, no, I just left him. He's coming home with me tomorrow morning. This can't be happening. And it's kind of like Sue Sheridan talks, you just think, no, he's in a hospital. He's in a safe place. This can't be happening. A couple days later, I was back in the hospital talking with people who explained to me that this was the result of medical error, that, the likelihood of the errors is what really caused his death. And so, you think about patient safety and you think about the IOM report and all the things were said in there, and then all of a sudden, if you're that person who's part of that statistic, it gets so very, very real, and it makes you realize this is why we do what we do. This is why we have to keep doing this, because people's lives are so affected.
And I want to say one thing about Sally, since she has the courage to tell this story. I remember meeting with Sally about 6 months after Dean's passing, and you don't address lawsuits here, but clearly in the case of what happened to Dean Romanis, the hospital was at fault and there were damages because a life was lost. And I remember the very difficult conversation with Sally. I couldn't imagine how I could face her. And what Sally said she wanted most was a broad, pervasive, continuous institutional commitment to patient safety. So in much the same way that Sue Sheridan did, what we embarked on in this hospital was because that was Sally's wish to try and make sense of what happened to her husband, Dean.
I can barely, I know that's, I so respect Sally for sharing it, and it still, I can't ever hear the story about Dean without being emotionally touched by it. Just so you know, what happened was that Dean, there was a complication of the surgery. It wasn't the complication of the procedure. He had a stent placed, and it perforated the coronary artery and began to fill the sac around the heart with blood. That wasn't the error. It was a complication. But throughout the night, as Dean began to struggle, the junior doctors failed to escalate the problem to a higher level and didn't appreciate the seriousness of the problem and began to treat the symptoms without understanding the cause. And so that was at 1 o'clock and 2 o'clock and 3 o'clock, and it was early in the year. So there were inexperienced doctors who were handling the situation. There were nurses who were advocating for escalation but didn't feel empowered to override the situation. And Dean continued to spiral down, and even at 4 in the morning, and then finally at 5 he begins to have an arrest. His pressure drops dramatically. They realize it needs to be escalated. They call in the attendings. They rush him to the lab, but it's too late. And it's all about hierarchy and communication and power levels within institutions, and fear of being told that you're weak and you're calling for help at a time when you should be able to handle it. And all these sorts of things that come together in a perfect storm. It occurs in the middle of the night just because of the timing. If it occurs in the day, it's probably a different story, but at night it causes that. And it remains tragic today. Sally, like Sue, turned it into something positive. She began to express leadership of our own patient safety efforts and has continued to tell a story that's difficult. She gave grand rounds and has given talks and has been an inspiration to us. But it's our need to tell these stories so that people can have them ringing in their minds when they feel inhibited to say, I think I see something that's not right. And to recognize that it's not about us or even how we feel. Sally herself was telling me this, that we'll get over embarrassment if we've moved too early or if we've flagged something that isn't a problem. But when we've missed something that could have been prevented, it can cause some tragedy that sticks with people their whole lives and has ripple effects. So I think that it's so important to share that, and we're so honored to have Sally as part of it.
Could I add one thing?
Please do, Mike.
Throughout the process of making the film, one of the things that we found difficult was the choice between telling one patient's story or telling many. And I think Sally is a great example of why telling one story is so important, because in many settings, the stories of harm, preventable harm, typically only have a few sentences worth of attention. What happened? It's typically all we hear, especially when it comes to the presentation of what happened so that we can talk about how. And we don't really get to hear a lot of the stories of the people who were affected by it. And I'm so impressed always when I see Sue Sheridan continue her journey, and when I see people like you out here talking about it years beyond when it happened, because they understand that to just acknowledge its existence is not going to solve anything, and to just say it happened is not going to help prevent it from happening again. And there are so many of these stories, and whether or not the number is 440,000 or whether it's 250 or whether it's less is not as important as the ability for those people to feel free to speak up about what happened from their perspective so a conversation can happen. And I don't know where the criticism lies if that's really the main point. The fact that there's a platform and it's growing for people who are in Sally's position or Sue's position to speak and share their story, I think is really important. And we felt a responsibility to share not just the story of what happened to Sue and her family, but her journey to becoming empowered, so that maybe another family will see that and feel empowered themselves to do that on their own terms and for whatever happened to them.
Does anyone in the audience want to have any comments, or just, I thought what we would do is have the panel reflect on a few things, and if the audience wants to participate, and then we'll go back and forth. There are a variety of other topics we want to touch on, but go in the back, and then James. Go ahead, please. Just introduce yourself. And
I'm Jessie Marcano Courtney.
I'm not sure it's work. Is it? It's my.
Can you guys hear me? Yeah. Okay.
Okay. Now.
I'm Jessie Marcano Courtney. I am a member of the Patient Family Advisory Council. I'm also a storyteller, so I definitely want to say that your story, Sally, it's impactful. Especially being on the council where all we talk about is how do we get communication from clinicians and medical professionals and patients and families. How do we get clear communication between the two? I thought that this movie was fantastic. One thing, though, that left questions in my mind was at the very end with AHRQ. I'm not sure if I'm getting the acronym wrong, but them basically kind of being dissolved and absorbed into the NIH. What does that mean for basically for the science of healthcare, of how we organize, how transparent doctors are, when we're talking about how care is given to patients and when mistakes are made?
Well, thank you for what you're doing. I think that's great. I'd like to learn more about it. But the good news is we have to make a change to that text, because last week Congress passed a 3% increase for AHRQ for the next fiscal year. So this is good news. There are caveats. I'm sure that those increases come with responsibilities that are not only focused on patient safety. The entire budget is never only about patient safety anyway. But we're going to tweak that. We're not yet done with the film until it's released and out there forever. So we will always aim to update the statistics whenever we can, however we can. And in this case, it's important to acknowledge that, yes, they did get an increase in spending, a small one, but an increase. It's the first one in 10 years, I think. But that there is still a faction or a portion of people in very powerful positions who don't think that it's important. Now, if AHRQ is dissolved into the NIH, there will still be some form of a patient safety effort going on in NIH, where people who worked at AHRQ will hopefully be able to continue their work. But the budgets will be decreased. Their efforts will be pared down. So we don't know what it will look like. We do know that the way it is right now will no longer exist if that happens. So I think there will always be an element of federal investment in patient safety efforts. But there are groups out there, like Academy Health has a Friends of AHRQ group, where all these organizations work together to help give AHRQ a voice that they can't have themselves, to say, we need money, we need more money, frankly, but we need to always have this budget to do what we're doing and do it better. I think as data and research continues to pile up, we'll see that they're doing good work, and so are the people who they fund and give grants to, and hopefully that will in turn continue to allow them to, for now, kick the can down the road, but hopefully eventually have a much more stable ability to do their job.
Hi, I'm James Hamlin. I'm a journalist. Toward the middle of it, of the documentary, there is a segment about doctors and hospitals admitting error, and this movement from denying and going silent toward transparency and admission of guilt. Has there been some change in legal precedent or statutes that has allowed that to happen, where people are less afraid of being sued, or how has that taken place?
I'll start with that because our chief medical officer and I had a conversation about that. There is nothing that has changed in the in medical malpractice litigation that changes that. I think that organizations and individuals in organizations simply make the decision that is the right thing to do. Now, whenever there is an error made, whether or not there is identifiable harm to the patient, we encourage the responsible clinicians to talk with the patients about that. Patients still sue us when that happens, and that's not wrong, because in some cases people are entitled to damages. So I think it's a choice that individuals and organizations make, but we have made the decision to disclose, and it has nothing to do with medical malpractice litigation.
And one more note on that. I also think it's really important that the environment continues to change, where not only people who make errors in the future feel the ability to speak up about it and have a conversation with their colleagues about what happened, but also that those who made errors in the past can release some of that burden that they likely carry with themselves. It's likely, and I don't have the exact answer, but it's likely that the two doctors in the film who shared their incidents have addressed them, if not with the people who were involved, with future patients. And it allows them, by acknowledging it, to protect themselves from future mistakes. And if we just continue to, if anybody sweeps a mistake under the rug, whether it's in medicine or any other setting, it's unlikely that they will have the power to prevent themselves from doing it again. That's why I think it's important to share that, to allow at least two people in the film who have at that point proven that they are reputable, to also share that they've made mistakes.
From the family's perspective, because my experience was an opportunity to talk to the physician involved directly, that ability to have that conversation is tremendously healing for both of you, for the team and the person involved, because people don't do these things out of maliciousness. That's such a rarity. And so for people to be able to face each other and say, I'm sorry that happened, that was never my intention, and let's talk about it. is a tremendously healing experience, which helps everybody move forward.
The research would suggest that the sharing of information doesn't actually bring about any increased litigation. The litigation comes from people who feel actually alienated and lack of trust within the system rather than, I wouldn't say that doesn't ever occur, but it's usually not what it is. We need malpractice reform. I think, like vaccines, we need a way to compensate people for damages that is fair and equitable and addresses it for everyone, not just people who sue. Many people don't sue because they don't feel empowered actually even to sue, and yet actually would benefit from damages from things that occur. We need a system that works that way. But if you look across all healthcare systems, even those in which malpractice isn't an issue, these issues are endemic. So this is, I think, more about the culture of medicine and how we as humans react to making mistakes and being ashamed and not wanting to confront it. And this is a cultural issue that we need to shift on.
It sounds like patients are part of the culture of patient safety, and just what efforts are we making to enable them to ask appropriate questions and to educate them as to what the appropriate questions are when they're coming to the hospital for an elective experience, or even if they're coming in as an emergency?
Well, kind of going back to your original question about the omissions in the film, I mean, we interviewed Marianne McGuckin, who wrote a book called The Patient Checklist, Patient Safety Checklist, sorry. And in reading that in preparation to interview her, there's some really good stuff in there that patients can legitimately take with them or provide for a family member as an advocate. And it's difficult because it does hurt the flow of a film to put a list of things up. It's not a PowerPoint slide, But I do think that providing that information in a setting that is easily accessible and promoted by those in medicine will only serve to help patients be better at that experience. I'm still having a hard time when I see a doctor in care asking them to wash their hands. And that was one of the big takeaways we want patients to have, is that they have the power to ask for the doctor to wash their hands, or nurse or whomever, if they feel like they haven't, because the numbers say they might not have. That's a really tough thing to ask patients to do, and so are probably many of the other things on the checklists that would be written. But it's important that patients know that they exist in the first place.
I think the other issue is that you hear a lot of talk now about merging the patient experience work with the patient safety work, and to me that makes complete sense. If you create an environment where people feel listened to and comfortable enough to raise issues and can say, you didn't wash your hands, do you mind doing that? It's a safer environment. So we have to somehow create that culture where it's okay for people to point things out to each other, to get each other's back, to cross-check each other and say, we're humans, we need that, but we have to create that environment where patients' families are comfortable enough to say that.
There's also a huge stigma that is going to be very hard to break. And it's up to each individual whether or not they feel like it's more dangerous to let a doctor touch them or clinician touch them who hasn't washed their hands versus telling them to wash their hands. Because I'm sure many people in their minds think the result will be much worse for them if they piss off their doctor. And I know many people who have had long discussions with about this movie who feel that way. It's just a human, it's the human condition. And the only way that's going to change, in my opinion, is if those who provide the care make it fairly obvious to the people receiving the care that that's something they expect. That's why that's one of the things Ashish Jha says in the movie. And I'm sure that's a very difficult thing to have standardized, but it would be nice.
I wanted to ask Gretchen Berland, a physician filmmaker in our midst, if you just would reflect a little bit on what you saw and what your thoughts were about the film. And
so I've never met you, but thank you so much for this beautiful film. I've seen 2 versions, thanks to Dr. Foreman, and I love both cuts, but I love the second cut more. Because you managed to, can you hear me?
Just have to talk right and put it right to your mouth.
Yeah, but then you hear me pop my peas. But so it was a beautiful film, and it worked for many reasons, which I'm sure you're going to hear about and have already heard about. A, that it kind of blended policy and patient story in a way that we all kind of connected, and it moved us, and it made us think about very difficult problems. So thank you for doing that. I hope that this film reaches many audiences. I think that it should go on PBS, and it should go on multiple festivals, and the New England Journal of Medicine should publish it at the same time so that it reaches many, many audiences. So that's my shout out for as a filmmaker. As a physician, I am now one of the firm chiefs on medicine, generalist firm, and I can tell you that hearing what Harlan says about patient safety and Sue Sheridan words, I think patient safety isn't glamorous enough yet. It's not really sort of quite kind of caught the cachet of some of the other things we talk about in medicine, and I think it needs to become. I think it needs to come back front and center again. I think the issue of culture and communication and how we study behaviors and culture and communication, we mostly still do it retrospectively, and systems that study that and systems that can kind of create that, I know that we're working on it, but I think that we're still not there. And that visual information and audio information that we saw in the surgical safety box, that's a wonderful new piece that you added, and I really love that. And I think that should be, we now live in a time where we have technologies. Even 5 years ago, we didn't have those technologies. So that potentially can help us either not only empower healthcare teams, but empower patients, which is a big part of this.
So I wanted to, thank you. I wanted to pick up on that, and maybe Marna, this is something that you can come on it. Actually, Gretchen and I years ago were talking about that we could be using video to a much greater extent within the hospitals. Now we have issues of privacy and that, we have to think about, but that video is a very powerful thing, and I remember when I talked to Gretchen about it, I said, well, I just don't understand why, in that time, John Madden was doing the NFL announcing on the game, and we'd see a replay of something, and he'd be drawing all this circles around where people were standing. And now it's much more sophisticated. I mean, actually, they're showing us in 3 dimensions, and the whole thing's rotating, where they're showing where's everyone standing vis-a-vis everyone else, and when one person moves, where the other, what's the spacing in the field, who's passing the ball to who's, and if in sports we're moving in that direction, and people obviously it's big money, and people are willing to invest lots of resources to be able to do that. On the soccer field, for example, everyone's wearing a sensor. And so they're actually knowing how much does each person run, where do they run, how they run vis-a-vis other people. I mean, they're perfecting it. And Atul Gawande was talking about this in one of his New Yorker pieces about coaching, as a surgeon, and in that time they weren't using video, though John Berkmeyer did this out of Dartmouth, where they did video of people doing bariatric surgery, and we're looking at the differences in the way people were moving their hands, and people with jerky motion were getting worse outcomes than people with smooth motion. And so at the end of this long prelude, the question is, what do you think about the role of technology in improving performance, and in particularly with regard to safety? And have you seen or heard, or do you see this as a way for us to be at the vanguard, to maybe even make a commitment to say, let's start rapidly vetting ways that we can assist ourselves? Because the pilots, the autopilot, and the various technology systems were one of the ways that airline safety was improved. One of the ways. Culture I always put first, but there were other assists. Do you see this on the horizon? Have you heard much about it?
I've heard some, and what I would say is there's always more we can do, and this is a journey. But you think about Captain Sullenberger's comments. In 2014, we made a commitment, as did every hospital in the state of Connecticut, that we were going to become high reliability organizations, picking up the same principles that work in the airline industry. And when we started that, we had about 14,000 events reported in an internal patient safety reporting database. 14,000 a year, that sounds like a lot. And 3 years later, it was 24,000. and growing. And we viewed that as a good sign, because what it said is, rather than being afraid of telling people that you made a mistake, people were talking about it. Technology, I think has been helpful. We have several programs that use simulation for interventional procedures, for training nurses, for a variety of things. We have videos online that are being used to reinforce patient safety. I'm probably one of the least technology-oriented people you could imagine, so what's actually happening out there and what more can be done, but I don't think there's a one-size-fits-all. Some people learn by participating through technology. Other people learn by storytelling. There are a whole variety of ways, but something that I would just like to say is, if you come to this organization or any of the organizations in our health system, including on a Saturday or Sunday, at 8 o'clock in the morning, there are people who gather from every discipline throughout the health system for a morning safety report. People don't sit down because it's not intended to be a long conversation, but there's a very regimented approach where they say, it's been X number of days since our last serious safety event. And then we give an update on, the air traffic control here. How many patients are in the emergency room who have been admitted and for whom a bed hasn't been found? What is the occupancy of various units? How many people were birthed in the patient post-surgical care unit because there weren't beds available? So you get a sense of how much is moving on. And then they go through a roll call, and they start with ambulatory and they end with whoever is closest to Z. But patient transport, medicine, surgery, transplant, any issues to report in the last 24 hours. And people report those issues. And if there's something that happened, a follow-up plan is made, and it's in real time. Are you going to report this back tomorrow, or do you need 2 or 3 days? And those are reported back. Then they go into, are there any great safety catches? And it's one of the most enjoyable parts of it. But here, and I'll give you just 2, and these are in the last week. A safety catch in the operating room was when a nurse noticed in an ophthalmology case that what she thought was the wrong eye was being draped for surgery. And she looked in Epic, and then she turned to the surgeon, and she did what we call in high reliability, she stopped the line. And she said, I think that's the wrong eye. What the surgeon did was he looked down, looked at his his chart or his notes that he had, and he said, oh my God, you're right. Thank you. And so what they did is they probably lost 3 minutes total in that case. The correct eye was draped. There was no error to the, harm to the patient. But what happened is now nurses feel comfortable saying, hey, I don't think that's the right eye. And rather than getting angry, the physician says, thank you for that. I had an opportunity to shadow a patient transporter for a morning 3 weeks ago, and he got a call to go up and transport a patient in one of the medical intensive care units to radiology. And we got up there, and this is a patient transporter, and he looked at the patient, looked at the equipment he had. He said, I don't know that this patient is safe to transport. What he did was his internal smoke detector went off. He said, I don't think they've made the right connections here. He arced up his concern. He found the primary nurse. Primary nurse said, oh, no, we're going to get a portable x-ray in here because this patient definitely is not safe enough to transport. Those happened both within the last couple of weeks. Those are an example. So storytelling is powerful because then when there is a more complicated patient issue that occurs, I think it's once a month, but you're going to correct me. We meet in this room, and anybody can come. You don't have to work here, but you come. And what we do is we do a full review of what happened, why it happened, and what institutional changes have been made, not just in this organization, but at Bridgeport, at Greenwich, at Lawrence and Memorial, if there are any teachings, learnings for that. So I think technology is a piece of it, but I also think that discipline openness, storytelling. I mean, all of these things are very powerful to change the culture.
Thank you. Let's say I've seen this command center. I think it's a nice combination of operational excellence and technology to give you the information you need to make the decisions. It's a remarkable good thing. Any comments from the audience either about technology or anything you've heard before we go on? Or Mike, you've got something?
Yeah.
Please go. Okay. Let Mike go and then you go. Okay. Just 1 second.
I just think it's interesting timing-wise, that question, because I think it was yesterday or 2 days ago, Terry Fairbanks, who does human factors research at MedStar Health in Baltimore area, posted a study about how they now really feel confident that EHRs are another contributor for patient harm, right? And this is a different topic in many ways, but the overlap, I think, is that technology brings its own issue. You know, every piece of technology you add to the picture can present new challenges, especially if you're training a workforce that's not used to it. And that should be assumed by everybody. But, you know, one of the reasons we wanted to interview Bob Wachter in the film is because of his incredible research on technology's role in healthcare. And to promote another documentary that I don't know much about, but is premiering at Tribeca Film Festival soon. It's made by some of the best documentary filmmakers in the world, some of my favorites, and it's very specifically about technology's role in harm in medicine. And I think it's just always going to be important to carry that conversation along whenever anybody introduces technology, to not forget that there's a human on the other side of it, and they have to be trained properly, and they have to understand the technology, because if they're pulling down a click bar and there's 50 things and they click the wrong thing, that could be a diagnostic error, the tiniest little piece, and you get the Swiss cheese model thing, and goes all the way to the end where the patient is. I think technology is awesome, especially the new gadgets, and I want to see them applied properly, but at the same time, this is obviously a human issue at the core, and I always think that's an important thing to address.
So hi, my name's Ian Ingram, and I'm with a reporter with MedPage Today. Largely the healthcare industry seems like a for-profit industry, and I guess I'm curious what mechanisms might be in place to ensure that some of these improvements in safety are made. I mean, you talk about the improvements in central line infections in your film, and implementing all that. Some of it might be inexpensive, some of it might be expensive. I guess my question is sort of, what are these mechanisms that make sure hospitals across the nation are making sure to make improvements like this?
That sounds like a Marna question.
What are the mechanisms? One of the people interviewed here was Mark Jason from the Joint Commission, and they survey and accredit hospitals across the country. There are other similar organizations that do that. They have a pretty finely tuned patient safety review process. And there are basic things that are life safety expectations that every organization has either invested in, put in place as a system, whatever, or you're not accredited. But I think, when you take there are gradations of everything, and I think it goes to the culture of the organization. We have one strategy for the entire health system, and that is to try and deliver unparalleled value. How do we define value? On the numerator, it's the quality of the care, objective quality. It's the safety of that care, and this is how we measure it. And it is the patient's experience. And in reality, the only thing patients can evaluate is their experience. But, it's all wrapped together, divided by the cost price point that increasingly people have to reach into their pockets and pay for. And it's a pretty difficult equation to get right because, governmental payment and how much you're paid and how much of your patients are governmental versus commercial. It all gets very difficult to measure this in traditional terms the way you would if you were going to go and buy a new television or a new pair of shoes and you had a better way of assessing that value. But in our organization, having a culture of safety is something that every person in this organization their compensation is based on that. Mine is, and the person who's burnishing the floor up in the cancer center also has an incentive program that's based on that. So, you know, we have tried to say, first and foremost, the most important thing is to have a culture that respects quality, safety, and how the patient experiences that. And, you know, and you're still going to have to make choices because there are not limitless funds to do everything. But, you know, I think that in general, people are inspired to make some pretty sound choices most of the time.
Please, go back.
Good evening, everyone. My name is Sumit Pawar. I'm one of the first-year cardiology fellows. And, you know, I would just want to thank Mike for sharing these immensely powerful stories, and also Sally, because, you know, when you shared your personal experience, I realized that I could have easily been one of those doctors. You know, beginning my fellowship back in July, I could have easily made that mistake. And I think it's very hard to, you know, admit and be courageous to realize that a physician, you know, make mistakes. And I just think, and I wonder if that's one of the big impediments for healthcare not being able to advance as much as aviation, because we as doctors always find it difficult to admit our mistakes.
Thank you for that comment. Yes, you want to respond to that?
No, along that line.
There was all you want. Well,
I'll be very brief because.
No, please. Sorry.
The title is To Err is Human. Maybe somewhere up there you could put, but to give us for divine. Because in a lot of ways what's been talked about is that by understanding, talking, deciding what is really best, that is really what you're doing. That was all.
Thank you. I want to actually, I'm glad you said that. I know that the general reaction to err is human is to finish it with to forgive is divine. And I do think that that's a very important message to share. But when it came to the first thing that we put on screen was a different version of that quote, and actually a much older version of the quote, which was to forgive is, or to err is human, to persist in error is diabolical. Now I will admit that at that stage in the film we're still kind of setting the tone of, well, errors are going to happen, and to not address them, to not fix them, is diabolical. I think that it's important to forgive mistakes if there are methods put into place once that mistake is addressed to fix it, not to do it again. Because I don't think there's anything to forgive if somebody knows that they messed up and doesn't care. That's I think, a very important message for people to understand about mistakes.
I had a question, maybe Sally, you want to reflect on this, which is, at one point in the film, we heard this thing about Sullenberger, you know, that was almost like, thank goodness we had experience in the cockpit. And, you know, I almost saw that as antithetical to the idea that we need systems that are indifferent to the amount of years of experience you've had, because you're fitting into a system and team in a way that means that even as a first-year person, you're protected as from, and you know, all of this is not about getting people to zero errors. It's about getting us to zero harm. So it's about that people are capable of making misjudgments, but are they protected by a system that ensures that the net is that there's not a harm? That doctor made an error, or whoever draped that patient made an error, but they were enveloped by a team and a system that made sure that whatever that Swiss cheese was, the holes were smaller and there were more layers. That made it almost impossible to do the wrong thing because of the way in which it was configured. It wasn't a lucky day, I hope, that nurse moved forward. That was a routine day that nurse moved forward. And so we're a teaching institution, and we do have people that come in July who are given all of a sudden much more responsibility than they had just a month earlier, and are put in positions where their actions have much greater consequences than they did just a month or so before. You know, what did happen to Dean, I believe, was in part related to experience in the time of year and the culture of hierarchy. Well, I think one of the questions is, what can we do to ensure that regardless of whether you've been in practice 5 years, 10 years, or a month, that you're in a situation where we can prevent harm? We don't need a heroic action. What we need is the routine action that we expect in order to get to Marna's point about the high reliability, is that we can't have that variation. I don't know, Sally, have you thought, because in your role as a patient safety professional, not necessarily in the experience you've had.
Yeah, I think that my experience is that we need a major cultural shift. I mean, we've gone from thinking that if you have experience and skill and knowledge, that's what you want in the room, that's what you want at your bedside. But what we've learned is that individuals alone are fraught with error, that we forget things and we get confused and, we have a moment of something. So I think that the takeaway is go back, talk with people when you leave here about this, and invite people in to work with you and say, I'll watch your back, you watch my back. The most safe teams are those that work well as teams, where people know each other's names, they talk to each other, they're watching out for each other. I mean, I don't care how smart or capable someone is, if you're not working as a team and you don't have people watching out for you, you're in danger of slipping on the ice and kind of going over the edge. And I think that comment about the cockpit, to me, is that. It's like they had to work in simulation, they had to know each other, they had to learn to function as teams, knowing that it doesn't matter how good the pilot is, if he's up there alone and no one's helping him, he can make a mistake.
Something somebody said to me recently when talking about that exact scene was, well, the reason why pilots care so much is because they're the first ones at the scene of the accident. And yeah, it's an interesting way of looking at it. And when you think about it in comparison to medicine, the provider is likely the first one there, but they might not be experiencing the result. I don't think that needs to be the reason why somebody's supposed to care, or why methods can be put in place to prevent those mistakes. But it brings up the really difficult conversation about how to actually address it. Is it punishment? No, I don't think so. I think it's a cultural shift, like you said. But how do you do a cultural shift nowadays? It's very different than it was 10 years ago. And it requires millions of people marching on the streets. And that doesn't even always do it. So that's the question we couldn't really answer in the film. What's the thing that we're going to be able to do to just fix it? I don't think that answer is available at this moment. But by having an opportunity to have discussions like this, my hope is that groups of people will start to come up with similar ideas, and maybe that will then join as a forceful unit of people who want change nationally or globally. So it's obviously the hard thing is to say there's no answer, but that I think the answer is forming behind the scenes right now.
Well, I think taking a cue from your dad about alignment, there is a historic alignment of interest in terms of trying to make this. My own feeling about this is that it's about cognitive dissonance. Because as a doctor delivering the care, actually, it's hard to remember errors, and you have an inflated sense of performance. But the moment that a doctor or their family member or a nurse or their family member become a patient, all you have are stories about the holes. All you have are stories about where there were gaps. I mean, all of a sudden your eyesight gets so much better, your sensors are so better attuned, and all of a sudden you are so much more aware of where the vulnerabilities are. And this I think gets to Marna's point too, which is that, I mean, it may be that technology is part of the solution, but culture and storytelling and the ways that we get people to see that what somehow the socialization process as a medical professional, because we were always told you got to be dispassionate, like you can't get too connected to your patients because you'll be dragged down. There's too many stories every day. I mean, in essence, that was certainly when I was trained. It was sort of like the more emotionally connected you were, sort of people would warn you against that. You've got to be professional, dispassionate, and not feel that. And I think it also turned off our ability to sense and feel what other people were experiencing. I always said, actually, the title of the talk I gave at my graduation was Seeing Through the Patient's Eyes. I always thought the more that the doctors can see through the patient's eyes, the more attuned we are to the empathizing and understanding what they're going through. I mean, part of the Dean thing was relax, like not living what Dean was going. I'm a healthy guy. You just told me I went through a sexual procedure. Why am I feeling this? And instead it was sort of like, we got, and you've just got to learn, tough it out, put on your big boy pants, and, and that wasn't the thing that was part of it. It was not that at all. So I think, but pivoting to this piece, and I think for audience wisdom and the wisdom of the panel, Martin, if we wanted to be the very best in the country, and we said, look, we don't have to live with this, the harm that accrues. I mean, the aviation industry has got mistakes, but they found a way to mitigate. They didn't say we got to have a couple planes dropping every year because you just can't get any better than that. And so that's just the way it is, but we got to only 2 or 3 planes dropping a year, so that's pretty good. But they actually said we want no planes dropping. I mean, I'm sure that's an impossible goal forever, but that they just said we're going to get to be that highly ultra reliable organization. We have made the commitment here. We are working hard, and we've spent considerable resources. But is there a way for us to, I mean, if we did start to use our imagination to say, could there be a place that ultimately mitigated to the point where we did not have catastrophic harm at this institution as a result of medical action? Is it possible, and what would it take for us to get there? And I'd like to hear your thoughts, but I also like people in the room to think about, because I think it starts with saying what everybody says isn't possible is indeed possible. You just have to, and I believe we know 90% of what we need to know to get there. It's not that there's this great mystery unknown to do it. It's a lot of the blocking and tackling that we know about. But the question is, can we implement so that people are willing to submit to it? Because in medicine, particularly among doctors, we're still in a maverick mentality. Don't tell me what to do. I'm a professional. And the question is, can we, around the things that need to be done, can we bring into place a culture and achieve that?
Man, come on, Harlan. Yeah.
We can turn off the camera momentarily.
Harlan, if I knew the answer to that, I would have shared it already. I don't know that, but I think it really does get down to culture, and I think that one of the values and variables in that is a culture of accountability. Everybody has to be accountable for
the team, not just themselves, right?
Yes, for everything they do and are part of. And, in our value structure in the system, there are a lot of important patient-centered words and compassion and respect, but accountability is there as well, because you have to own it. I think that it's holding yourself accountable and people holding other people accountable, as if every patient and family member they encountered was related to them.
So how about ideas, please?
Yeah. I think culture is very important.
Introduce yourself to the...
Sorry?
You want to introduce yourself?
Oh, I'm Kevin Johnson, one of the radiologists.
I know who you are.
Yeah, I think culture is very important, I understand it. But, if you said to me, solve one of these problems, it's an engineering problem. A lot of these problems are engineering problems. Not all of them, but a lot of them are, and we have almost like no engineers around. If you look at the aviation industry, there's engineers everywhere, and the pilots interact with them in improving the culture. As Atul Gawande wrote about that in one of his books. But here, I've worked here for many years. I've never had any company or any engineer or anyone want to sit down with me and go over things to help improve things. So let's look at the electronic medical record, for example. It is not a narrative of the patient's experience. What happens to the patient when they're here, it should be fascinating. You should be able to sit down, it should be riveting. Everything that happens one after the other. And you should be able to scroll back and scroll forward and look at different body systems and look at the history of medication. It should all be there in a graphic, interactive way. And it's not. The EMR is like a data dump, right? So we expend a huge amount of our effort, for example, in maintaining the narrative, passing it from one into to the next, one resident to the next overnight. There are two narratives going on. There's the oral history of the patient here in the hospital, and there's the EMR. Very inadequate. And yet, We don't sit down with engineers. We don't give them the feedback. You know, we very much value, for example, in this institution, clinician scientists, very highly valued. Where are the clinician engineers? You know, we could have clinicians who have engineering backgrounds, who have engineering PhDs, who really sit down and look at human factor engineering, look at these different things, different systems that we could put in place. And that is completely lacking. And one of the reasons, my son actually does artificial intelligence research for DARPA and other things. And I said to him, Ben, why don't you get involved with some of this? He said, are you kidding me? I'm going to deal with the hospital and the hospital IT systems and all the HIPAA problems. He said, I'm not going to do that. And if you read about Silicon Valley, a lot of them, there's some efforts, but I mean, they've encountered huge roadblocks. Something Yale New Haven could do that would be just game-changing is to actually open yourself to that possibility. You could be a hub where startups, other places could come in and actually start to engineer some solutions.
Sorry, do you mind if I say something
No,
about that?
just quick, because I also want to get some of these solutions from the floor.
I just think it'd be interesting to see where that goes because of the constantly changing relationship people now have with technology, especially tech companies, with regards to privacy. It's not a great time. And I want to see that happen where technology meets transparency, especially in medicine. And even just trying to film stories at hospitals is a challenge because of the ability to just bring a camera in. So, yeah, I don't know. I mean, I'm not the one you're asking, but I would be really curious to see how things start to progress with privacy in the tech sector.
So last 10 minutes, let's get a lot of good suggestions about what we should do. And I will say the hospital has begun an initiative to try to work with innovation and companies and so forth. And I think it's a good suggestion, Kevin, and they're just really getting started. Go ahead, Diane. Do you want to?
So I went to...
Just introduce yourself just real quick.
Hi, I'm Diane Collins. I'm the performance manager for Heart and Vascular here at Yale New Haven. I have an idea that I had actually learned from IHI, from Mayo Clinic. It's, you know, it would be something that would be a lot of work, but it would definitely be something that I think we could do, at least maybe parts of it.
I can't wait. Just tell us. Come on.
So basically, you know, we've gone on to this HRO journey, and we've actually been able to reduce our
high reliability organization.
Right. And what to take it to the next level is you have to do a lot of the different things that we're talking about here all together at the same time by having an engineer, a nurse leader, a physician leader, everybody together, and their sole focus is how to change culture. So you kind of survey your units, your areas, and you say, where are my units that are at the highest level to be able to change? And let me start there. And then you basically have these groups of people who come and interview all of the individuals on those units. It takes a lot of time and a lot of manpower, but you actually get to some of the key things on each of the unit, the culture of the unit, the culture of the area, the culture of the department, to try to maybe change what their feelings are or why they why don't we do evidence-based practice here in this particular area? Why don't we adopt the safety culture? Why are we not washing our hands? Why? You know, because we have the tools sometimes, but we just don't understand why. And they were able to get to a lot of that, and they actually had, you know, a lot of groupthink and a lot of re-engineering of certain things that they had to do, but it wasn't one thing that they did. It was some technology, but it also was just listening and understanding, telling stories, and then also changing when you do handoff to, you know, not like when was our last fall, when was that, which is all very important, but what else did we do right? Like, yes, the great catches, but starting with the great catches, starting with all that stuff so that you point out the individuals and on the unit, not just at morning safety report.
Thank you. Next.
Michelle Johnson, I do interventional neuroradiology, and I wanted to go back to something that I think is a small piece, but it's an important piece of this. I enjoyed the film, and I wanted to take Sally's comment about the importance of putting patient safety and patient experience together. The segment with the PA student learning to tell bad news and to disclose an error, I think that it's actually a bigger story than that. It's the efforts that Mike Bannock has done with communications in the hospital and the medical school. It's being able to, if you establish good patient relations at the beginning, it makes the patient feel like they can ask you to wash their hands. It makes the patient family feel more empowered. And where it's not like you're doing it just in case you make an error so it'll be easier to explain. But I think that that piece of it, how we train our trainees and those of us who work in the hospital, if you can't train the trainee to do the right thing if you can't learn to do it yourself. So I think that we can't underestimate the value of the communications and the patient experience.
Great. Next, anyone? Gretchen? Yeah. And then in the back, next. It's okay, just quick. Okay, we'll go in the back and then we'll go down.
Good evening. My name is Kerry Smolinski. I'm one of the radiology technologists. I'm very thankful that I was invited to this. I enjoyed the film. It's excellent that we're starting to talk about this culture more openly, and it's actually filtered down to us at the technologist level. Many times we're working and we don't get to see the type of good work that's being done up here at the doctor and the manager level. What this is showing to us is that we are important and that our job is to mentor the other people that are coming underneath us so that they see our good habits. Not only are they empowered to tell us when we're not correct or we're not up to current standards that they're learning in school, but that we teach them this is how we do it and why we do it. That's very important to get them on board with us.
Thank you, that's exceptional. Next, anyone? Gretchen, do you want to?
I just had a side comment. I think
Then you go next.
Not related directly to patient safety, but related to culture, and that's the issue of burnout and stress within the provider, within the healthcare system. And I think that's a piece of, I know it's on everybody's radar, but it contributes to, I think, some of the kind of intractable issues that we deal with in terms of getting it, in terms of culture. So I'm not saying this isn't a new issue, but I would say it's a bigger one. But if I were to pitch an idea to Marna, I would say that I really think that Yale New Haven Hospital needs to create its own Yale New Haven Hospital phone, and that we provide videotaped discharge summaries to our patients so they can take home and watch them.
By the way, on the burnout thing, and we should chat because you're Filmmaker, right? Is that what I got? Because we're working on that to be our next project as a follow-up of sorts. It's a different challenge, and we haven't begun yet, but I think it's very important, like you said.
Great. You in back, and then you.
Mark Zezer with the New York State Health Foundation, and again, thank you for making this movie and sharing it. It's wonderful. And just from listening to all the comments and thinking about payment reform for many years, it seems like there are a lot of mechanisms to help change the culture and to help make it easier for the individual clinicians to make the right decisions and avoid errors. But it doesn't seem like there are good solutions yet for helping to make sure that the C-suite leaders, the managers of the departments, are going to prioritize that for the individual clinicians that are working there. I guess that's my question. Like, what types of information, what types of incentives should be put forward at that level so that they're willing to make these investments in artificial intelligence and to prioritize this public safety culture so that we can move towards Harlan's question about how do we get to zero errors and prioritize that ahead of a lot of the other daily concerns that these managers and C-suite executives have.
I think it's a good question. What I want to do is just take one more comment, and then we'll go final words. And if Marna, you can maybe reflect on that too as you Do that.
Hi, actually, my name's Hunter Smith, and I'm probably the only non-medical person in the room tonight. And I've been kind of on a journey of 12 years, and my sense of this evening, the movie and everything else is one of the word that comes to me is awareness. And it's through that awareness, through everything that's been done in patient safety, everything the hospital's committed to, your movie produces awareness for people who don't have a sense of all this. But everything that's been talked about is by people being aware of what others are doing and being aware that those changes should be made, and it's a priority. That just goes through that one word to me connects everything I've heard here and have seen about what's been going on. And I think it's through that people know, what they can do to move it forward. So.
Thank you. So Sally, want to just start with you, and then just brief, final words.
I think, that part of how we're going to move ahead, I agree with Mike and other people. We don't know the answer. I mean, we wish we did know the answer about how to move this ahead. But I do believe in the collective wisdom of groups, and I think that you all had some really great ideas here tonight, and that is what we need to do. We just need to continue to garner the information that people have and the ideas that people have and put them all together and continue to move this process forward. There is an answer out there, and we can't stop, and we have to keep pushing forward. We can't allow people to be hurt. So we just have to work together, I think, and share ideas and continue the discussion and continue to push the agenda forward.
I would just say ditto to what Sally said, because I think that if there was a silver bullet, if there was a really clear answer, if there was a way to harness a piece of artificial intelligence, a lot of people would be doing it. I think it's really multiple things. I think it's technology. I think it's systems changes. Diane, your idea, let's take a patient unit and pilot it and see if that unit is safer. I think that it's iterative, but it's going to be a lot about human beings, about culture, about respect. And, sometimes I think it's not the, big shiny objects that we invest in, but it's in our people looking at what we have and whether or not we're really maximizing the value of what we have.
I haven't used this analogy before, so bear with me. I'm coming up with it as I go. But I'm sort of thinking of this like a sculpture in the sense that, medicine is beyond the block. It's not, you're past that. I'm starting to figure out where to chip away to make this piece of patient safety and what it's going to look like when you're done. But even when that time comes, that sculpture can erode and that sculpture can change if it's left untouched and left uncared for. So one thing I've learned a lot over the course of making this film is that while we want to help from in our approach of filmmaking and storytelling to create awareness and to create a sense of some sort of solutions at the lowest level of training, at the highest level of creating technology, that it's not going to be it's not going to be an endless experience for anybody, and you have to continue to carry on that message to the next generation so that next time somebody doesn't get hurt. It will never stop. And so I hope that through the film and through the efforts that you guys have talked about here, some solutions can come out of it and can be addressed not only to the people in the room, but people outside the room and on Twitter and on Facebook, and let it just spread. So
I want to thank you, Mike and Kaylee and Matt, for what you guys put together in your team. By the way, the sound also, I saw you guys at the end, you got the sound, the whole thing as a wrapped was good, great, fantastic. You can see, I believe this film will find its best action as a catalyst. It's not something just to be seen and watched, but it's something to move people to action. And you have created a wonderful tribute to your dad. I know he'd be so proud. And you've created something that I think will make a great contribution. And you can see even tonight, what that has done. I want to thank Howie for all pulling this together in the logistics, to our wonderful panelists willing to share their time and stories, to an audience that was engaged and also shared their wisdom with us. I think that I was moved by so much about Sue, but she said I continue to believe we have not done all that we can do. And I think the best thing for me is to remember those words. I will tell you that tremendous progress has been made. It's little consolation that that progress has been made because we have still so far to go. And yet, the medical system, this institution, should take some pride in creating a system that is so much safer today than it was a decade ago. It's up to us now to take that to the next level and not to be complacent about that level of performance. And again, I share Sue's view. We have not done all that we can do. It's up to us to work together at every level of the institution. And by the way, it's not high and low level. It's just different levels. People have different roles and jobs. We need to respect and honor how everyone in this institution contributes to the greater whole, and we need to work together to make us all better so that we can get to the point where there is zero harm. And I think we need to drive till there is the day where there are no catastrophic injuries as a result of medical actions in this institution. And that's the day we're driving to. We're not driving to a day, it's unrealistic to drive to a day of zero errors, but we should drive to zero harm. And it's up to us to be creative, thoughtful, and also like what Mara said, my final point is she said, let's test it. Because we talk about accountability at the personal level, the accountability at the institutional level is not just to claim success for what we do, but for what we've achieved for people, what has occurred for people. So at the end, it's going to be whether we have zero harm, and then it's testing and being accountable as a group, as a team, as people who can hold hands together and know that that achievement was done by a group effort, not by any single hero and not by any single technology, but by a sense in the institution that we will use every tool, we will spend every resource, we will work every hour to ensure that there is no harm that occurs here as a result of us. And that at the same time we're working to do our best to mitigate any harm as a result of disease and illness that is occurring that has no relation to us. So with that, thank you very much. Thank you, Mike. Thank you, team.